Good morning, everyone. My name is Tanziyah. I'm one of the second-year neurology residents, and I'm going to be presenting an interesting case that we saw on the inpatient consult service just a couple of weeks ago. So the case is of a 69-year-old man. He's got a history of invasive metastatic urothelial squamous cell carcinoma, as well as hypertension, and he presented due to visual changes. He reported that when he returned home after his last chemotherapy cycle, approximately 3 weeks ago, he suddenly noticed that everything was much smaller than he remembered them being. He described sitting watching TV and how a 70-inch TV suddenly now looked 14 inches. His wife looked minuscule. His clothes looked so small that he had difficulty putting them on. His car was so tiny that he could no longer drive it. He denied any loss of vision. He denied any field cuts, no loss of visual acuity or loss of color vision. The symptoms have mildly improved since the initial onset, but he's still having significant difficulty with daily tasks. Some additional background: his last chemotherapy cycle was tolerated without much difficulty. He'd been hospitalized for about 3 to 4 days. He has been struggling with hypercalcemia of malignancy, and he did receive zoledronate last admission, and his chemotherapy consists of paclitaxel, ifosfamide, as well as cisplatin. His ophthalmologic exam was generally unremarkable. He had some minor field deficiencies in just the left eye. He had some cotton wool spots, some nonspecific findings on fundoscopic exam. His neurologic exam was unremarkable. Labs as well were all generally unremarkable. As far as his imaging, first I have these T2 flare sequences. He did have multiple lesions in bilateral occipital as well as parietal lobes, the largest of which is highlighted here, as you can see in the right occipital lobe. It looks primarily subcortical with a little bit of cortical involvement. The other lesions tended to be a little bit cortical. There was a small one in the left occipital lobe and a couple smaller ones in bilateral parietal lobes. The lesion in particular that I've highlighted does in fact contrast enhance in this T1 post-contrast image, and the enhancement shows some cortical enhancement as well as some subcortical enhancement as well. In terms of diffusion restriction sequences, the lesion in question does in fact diffusion restrict with some mixed ADC correlate, suggesting some kind of subacute to acute in terms of the etiology of this lesion. The other lesions in bilateral hemispheres had variable levels of diffusion restriction. So the differential, given kind of these findings, he's got multiple lesions in bilateral occipital and parietal lobes, likely consistent with multifocal acute and subacute strokes. However, the actual description of the lesion ongoing back and forth with radiology also has a little bit of a characteristic that could be suggestive of PRES. He did have a period of severe hypertension during his last admission, and there are some reports of cisplatin, other platinum-containing chemotherapy agents that can cause PRES. And since he does have a primary malignancy, these lesions could also be consistent with metastases to the brain. So as of now, the lesion itself is sort of up in the air in terms of what it is, and we plan to re-image him in 4 to 6 weeks and have him follow up with neuro-ophthalmology, with kind of the primary diagnosis likely being subacute and acute strokes given the time course and the nature of the lesions. However, the actual syndrome itself, which is what I'll talk about next, is something called Alice in Wonderland syndrome or Alice in Wonderland-like syndrome. What he described is seeing everything smaller than what it actually was, which is kind of in this cohort of disorders of perception that tend to include distortion of sensory perception, body image, or the experience of time. This syndrome was first coined by a British psychiatrist, John Todd, in 1955, a different Todd than what is named Todd's palsy. And this particular syndrome also tends to include visual distortions or metamorphopsias, and these are the most widely reported distortions in the literature. Some examples include akinetopsia, where someone is no longer able to perceive motion of objects, macropsia, where objects appear larger, micropsia, like our patient had, where objects appear smaller, mosaic vision, where essentially all objects have a more polygonal shape versus smooth contours, and trailing phenomenon, where a moving object essentially has still objects trailing behind it. The etiology is fairly diverse. There's only a handful of reports of this phenomenon in the literature. However, it's thought to be very underreported. One of the primary etiologies tends to be migraine, either a part of a migraine aura or during the migraine itself. Temporal lobe epilepsy has been shown to also possibly cause this. Strokes, as in this gentleman, most likely, a stroke may have caused this particular syndrome. Brain tumors, as well as encephalitides from various infectious diseases. And of course, substance-induced, including hallucinogens, cannabis, as well as cocaine. There are some reports of medications, such as risperidone and topiramate, causing this as well. In terms of the pathophysiology, as I mentioned, it's a fairly rarely reported syndrome in the literature, so it is, as of yet, fairly unclear. However, what is thought to be occurring is functional or structural disruptions in various cortical areas. In particular, when it comes to visual distortions, different cortical areas are responsible for processing various levels of higher order visual function. So, for example, area V4 is responsible for color vision, particularly. So lesions in this area can contribute to achromatopsia, where someone is no longer able to perceive vision or color vision. Area V5 responds to movement, and lesions in this area can cause akinetopsia, where someone's no longer able to perceive motion. And so depending on the organization of the visual cortex and where the lesion lies, select neuronal populations might be disrupted, and these populations may be responsible for higher order visual functions at the network level. There are non-CNS pathologies that can cause these syndromes. Dysmorphopsia, just essentially distorted vision, can be due to retinal disease, and plagiopsia, which essentially everything looks tilted, can be due to labyrinthine disease. Micropsia specifically, which is what our patient had, has been associated with occipital hypoactivation and parietal hyperactivation in one MRI study where they studied an individual that had episodic micropsia due to an encephalitis, and they were able to capture the imaging sequences while the patient was having micropsia. And here are my references, and thank you for your time and attention.
Thank you so much. A particularly cruel affliction for somebody expecting to watch the Super Bowl on a 70-inch TV. All right, everyone. Great job. So our speaker today is Dr. and Will, I'm not showing slides, is Dr. Heather Whitson. Heather is the professor of medicine, ophthalmology, and head and neck surgery. She's also the director of the Duke Center for the Study of Aging and Human Development. But we all know Heather as the co-director of the Duke UNC Alzheimer's Disease Research Center. Heather went to Cornell Weill Medical School and came to Duke for her residency in medicine and her fellowship in geriatrics. Heather's work explores the link between age-related changes in the brain and the eye, and also studies how to improve care options and resilience for older patients with multiple chronic conditions, especially in the setting of surgery. Heather is a remarkable scientist, clinician, and especially leader. She was able to take a group of about 100 people and within 6 months' time produce an NIH grant, the total amount of $14 million over 4 years that was funded on its first shot, which, you know, in my 35 years of experience was just a remarkable feat. And after celebrating that, now she has to ride herd on all her disparate crew, many of whom happen to be in the Department of Neurology. So anyway, we're thrilled to have Dr. Heather Whitson do grand rounds today. The title of her talk is A Disease of Aging, Not De-Aged: How the Duke UNC Alzheimer's Disease Research Center is Fighting Dementia Across the Lifespan. Heather, I'll turn it over to you.
All right. Well, thank you so much for that introduction. And Tanziyah, that was an amazing case. That I really enjoyed that case. As a person who's very interested in how the brain and the eyes interact. All right. Can you all see that?
Yep.
All right. I'm going to start out just quickly with my disclosures. I'm entirely funded by the feds. And so for our outline today, so I wanted to sort of obviously, as Rich just discussed, the thing that's occupying a lot of our time and energy and on our minds, and we're super excited about right now, is the Alzheimer's Disease Research Center. So I'm going to talk just a little bit about that new center and its theme, and then try to give you 3 examples. And I will tell you, it was really hard for me to choose 3 to talk about examples of how we can apply this theme of thinking about Alzheimer's disease as a disease of aging, not just the aged or old, not just a disease that's relevant in late life, but a disease that evolves across the lifespan. I chose these 3 because they all have some special significance to me, and I'll tell you what that is as we go along. And then finally, I want to close with just talking about, the point of the ADRC is to be a service and a resource to our community. So to touch on how the ADRC can help you, and how hopefully a talk like this will stimulate you to think of some other way that our theme could be applied and relevant to your own work, and you might partner with us. So what does it mean when we say that the NIH, or that Duke has a new ADRC? So the NIH designates about 30 centers of excellence in Alzheimer's disease and dementia. And in early 2020, really spearheaded by Rich O'Brien and others, and with the support of the dean and translating Duke Health, Duke decided to organize a movement to get one of these centers of excellence at Duke. And then in early 2020, Duke and UNC decided to establish this partnership and apply jointly for an Alzheimer's disease center, given sort of complementary strengths at both schools in the area of Alzheimer's disease and dementia research. And the meeting that we had where we made the call to do this happened in late February 2020. So we all know what happened in mid-March 2020 when the pandemic hit. So just as Rich said, we then sort of went into pandemic mode, where in addition to doing everything that we were doing in the clinical world, we were writing this grant. But as this is a story with a happy twist, which is that just as Rich just described, with a huge team effort and a heavy lift, as you can see here, all the departments at the schools that are represented. We may be one of the only ADRCs that have faculty drawn from obstetrics and gynecology because of our interest in how perimenopause and changes through menopause may affect the aging brain. But we are essentially 2 schools, 11 departments crossing those 2 schools, 996 pages of a grant, and a single common unifying goal, which is to make a dent in this very bad disease. So our motto, our mantra is, when it comes to fighting Alzheimer's disease, we're all on the same team. And it's a big team, as Rich said. You can see as those that I could fit on the lower banner, across the banner, and also those whose likenesses appear on the internet and could be easily found. Our vision is about transforming both care and research across our catchment area. The NIH makes you define a catchment area. We defined ours as Eastern North Carolina. So sort of where we are east of here. And then what do we do? So we do essentially 2 things. We contribute locally generated human data from people that we enroll as participants in our study. And we feed that data, we contribute that data to the national databases and repositories that are to support ADRD research. In addition to that, we look to be a very outward-facing center, a local resource for people at Duke and UNC. And in our case, we also have partner schools. So partner schools in Eastern North Carolina include NCCU, UNC Pembroke, and ECU. So we're really looking to provide training opportunities, funding opportunities, and resources to help support and stimulate ADRD research. But what that means is that many of the research ideas will bubble up naturally from the local investigators. What we provide is a theme. And the theme of the Duke UNC Alzheimer's Disease Research Center is this idea of Alzheimer's disease as a condition that's developing across the lifespan. So what we certainly know and understand is that a certain amount of our risk for developing Alzheimer's disease is determined at birth. So probably most people my age and older know that one of the things that Duke is well known for is that Alan Rosas identified the link between the ApoE4 allele and Alzheimer's disease, and that still today remains one of the major risk factors for Alzheimer's disease and the most important genetic risk factor for Alzheimer's disease. But the largest risk factor for Alzheimer's disease is age. So what we know is that people who are born, even with this genetic risk and high propensity to develop Alzheimer's disease, firstly, they don't all develop Alzheimer's disease before they die. And secondly, those who do and have late onset Alzheimer's disease tend to live 6 or 7 decades without manifesting the disease. And so we're very curious about what are the things that happen across the lifespan that sort of open the door for that disease to manifest or unlock that genetic propensity and cause the disease. What we know is that the pathological features that are associated with Alzheimer's disease, amyloid and tau, those develop in the brain often before symptoms appear, and even as much as decades before those pathological findings can be detected, we know that changes are also happening in the brain. So changes happening in the brain years to decades before the pathology is present, before the symptoms manifest. So what's happening? So we're really looking for what are all those things, whether it is comorbidities, below the neck conditions that change and contribute either directly to the development and progression of those pathologies or to the experience of living with Alzheimer's disease, meaning the way the symptoms manifest and are dealt with. We're also interested in sort of aging at a molecular and cellular level. So what's been termed the biology of aging. And we think about this a lot in the Aging Center in the context of what's been defined as these pillars of aging. They're also sometimes called in a slightly different framework, the hallmarks of aging. But essentially the idea that if I gave you 2 tissues, one from an old animal and one from a young animal, there are certain features of those tissues that you could look at the molecular and cellular level and make an estimation as to which one came from the young animal and which one came from the old animal without knowing otherwise. And those things we consider the sort of hallmarks of aging, or the pillars that drive aging biology. The thought being that if we can create more favorable biology in these pillars for a longer amount of time, we're essentially targeting the aging process itself. So our question in the center is how does the biology of aging potentially open the door for the changes that we see in the brain associated with Alzheimer's disease and other dementias? I also want to, and I know to this crowd, I'm telling you something you already know, but that is that dementia is this heterogeneous mix of pathologies. So dementia is obviously a clinical syndrome that is determined by people's clinical symptoms of memory loss and cognitive changes. Underlying that, and it's now increasingly obvious that although we like to sort of sort the different dementias by name, Alzheimer's disease, Lewy body, late, that in truth, the pathology in the brain doesn't always follow those rules exactly, and that we often see overlapping and heterogeneous pathologies. And then the other thing that's happening sort of around these pathological characteristics associated with different types of dementia is that the brain is experiencing changes in its blood flow, the inflammasome of the brain, or the immune milieu of the brain, cellular metabolism of both neurons and other cells in the brain. And then the brain can be exposed to injuries or exposures. And all of these are driving the sort of ultimate thing that we care about, which is the symptoms that we see of dementia. So we're interested in how age-related changes in any of these things or exposures over the lifetime are driving either the development of pathology, the underlying pathology and changes, its progression, or just the experience and the manifestation of the symptoms. So now I'm going to give you just 3 examples. And as I said, there are many, many examples that could have been chosen. I've picked some that have particular significance to me. The first one is thinking about age-related changes in vascular health, and particularly focusing on the period around midlife. So This is a case. This is a 79-year-old man who presented for dementia workup. He is a retired statistics professor of Native American Lumbee Indian. He complained of 2 to 3 years of subjective executive dysfunction and memory loss, past medical history, only hypertension and prostate cancer. Now, the reason that this one has personal significance to me is that this is also my father-in-law. So that's my little niece with my father-in-law. Monday would have been his 89th birthday. He passed away in 2016. So his presentation, as you can see, at the time that he presented with what was clearly early dementia, he had, although he was socially very well preserved, his MoCA was 22 out of 30, which would have been a significant change from his baseline. And over the next 3.5 years, a very difficult time ensued for my family, where he had progressive cognitive decline, multiple episodes of delirium. In addition, he had a lot of mobility issues with worsening balance and multiple falls. And what you can see from this MRI when he first presented and had this as part of his workup is he had known hypertension, reasonably well controlled, but known hypertension. And you can see a lot of, there's a likely silent stroke that he had at some point in his life there with the green arrow, as well as just lots of periventricular white matter. So the answer is that in his case, we don't know what the pathologies were. He did not have a brain biopsy at the time of his death or an autopsy. But I suspect that he probably had other pathologies. We don't know which, but I certainly think that his vascular disease contributed to the likely progression of those. Now, again, why is this particularly interesting to me as an opportunity to, in midlife, start thinking about what we could do to protect the vascular health of the brain and slow down progressions of dementia like this? So this is another patient case. This one is my husband. So when we were 43, we're now 47 and 40, almost 48, and I'm already 48. But when we were 43, I was driving home from work one day, talking to my husband on the phone as he was actually driving home from work too, from the RTP. And he said, you know, one side of my mouth has been feeling funny all day since I left the gym this morning. He left the gym about 7:30. This is about 5:30 at night. So about 10 hours. So I was actually about to go to the gym myself, but I said, I don't like the sound of that. What are you talking about? And he said, yeah, it's just one side of my mouth. It almost feels like it's not moving right. It's been numb all day. I feel like that side's, I'm like drooling. So I said, all right, meeting you at home. This is what.
My name is Ben. My name is Ben.
I'll play that again for you. This was actually when we were sitting in the ER, because I could tell when I got home and took a look at his face, which is obviously very familiar to me, but I could very well see that on the left, you can sort of see the left nasolabial fold is not very prominent.
My name is Ben. My name is Ben.
All right. So MRI that night, and in fact, he did have what was likely an acute infarct in the right frontal corona radiata. So this was a subcortical ischemic stroke. He's 43 years old. So he fortunately made an almost full recovery. So he continues to have numbness on that side and will occasionally feel that he still has a little bit of the salivatory and motor symptoms, but mostly it's just numbness. As you can see, he's kind of a fitness nut. This was him about 3 months post-stroke on a dare from my kids doing upside down push-ups on that parallel bars, which I certainly could never have done, and certainly not 3 months after a minor stroke. But what as a geriatrician, and he is a son of a person who experienced dementia, was most worried about was what he could do now that would reduce the risk of one day having an MRI like the one that his dad presented with, and most importantly, having the symptoms. So he certainly has remained attentive to diet and exercise. He gave up occasional cigars, lots of new medications. And the important thing here is his systolic blood pressure target is less than 120. And that is a change. As most of you probably know, midlife hypertension has long been associated with dementia risk from an epidemiological standpoint. There's lots of good data out there that even in the 30s and 40s, people who have hypertension are more likely to have dementia. But what we have now is the first ever randomized controlled trial data that in people, I'm going to call it midlife. This study was actually enrolled people who were 50 and older. So he wouldn't have quite made the cut, but we're applying the data to him. This is the SPRINT MIND trial. So it randomized people to either intensive blood pressure control. These were people who had hypertension plus at least one other vascular risk factor. Randomized them to either a target systolic blood pressure of less than 140, which was kind of old standard, versus more intensive arm of less than 120. There was no prescriptiveness as to what medications were used to achieve those targets. And the study was actually stopped early for benefit, both in the primary outcomes, which had to do with cardiovascular events, but also the SPRINT MIND trial, which was an always planned sub-study with the outcome of MCI or dementia. The reason that it wasn't just dementia is especially because it was stopped early. There were not enough dementia cases to look at its preventive effect on just dementia, but with MCI and dementia as a composite outcome, clear benefit in terms of the lower blood pressure target. And in fact, I sit on this CDC expert panel, which is reviewing and evaluating sort of current evidence for the CDC related to delaying the onset of cognitive decline or dementia, and trying to create sort of a public health toolkit. 9 opportunities have been identified to intervene, but the only one that so far has randomized controlled trial evidence is intensive blood pressure control. So many questions remain though, and this is where I hope to stimulate people's interest in potentially going further and developing additional evidence for staving off cognitive changes in late life. As I said, there's a lot of observational data at this point that point toward the importance of other vascular risk factors, not just hypertension, but there are a lot of gaps to still be filled. And so I think that Duke is a place and UNC is a place where we could potentially move the science forward here in terms of understanding mechanism and also doing the studies to understand preventive potential here. So the risk of dementia is lower in people who don't have obesity, type 2 diabetes, or hyperlipidemia, but it's totally unknown at this point if treatment of these risk factors in mid-life or in late life lower dementia risk. There is at Duke, is leading as the coordinating center for the preventable trial, a major multi-center trial that many of you are probably aware of, that's randomizing people to atorvastatin versus placebo in late life. So these are people who are 75 plus years old, do not have any cognitive problems. And one of the main outcomes is to see if atorvastatin that late in life can prevent or delay cognitive changes. All right, so with vascular as my first example, I think most people would believe and would buy that something about vascular health, the blood flow to the brain, and the vasculature itself and the ability to clear toxins from the brain, something about vascular health may actually drive the deposition or accumulation of those pathological features associated with different kinds of dementia. I'm now going to switch to one that I think it is probably less likely that people who lose vision in late mid or late life, that somehow drives the accumulation of tau. But I think that there's a really strong case that it could very well affect the brain, the cognitive resilience of the brain, which is essentially the mind's ability to maintain its function and cognitive performance in the setting of neuropathological disease. So this one, the reason that I chose to focus on this one is this is my own area of interest. I've long been interested in sort of the eye-brain connection. And I'm going to show you just a little bit of data here about what we know about what late life vision loss does to the aging brain. So first of all, this is a summary figure from a NIA conference that I co-chaired with Frank Lin, who Frank Lin essentially asks this question related to hearing loss and the aging brain. And I and others are interested in this question related to vision loss in the aging brain. So we led this conference that focused on both vision and hearing impairments and the strong, again, epidemiological link to cognitive functioning. So it's very clear from epidemiological evidence. The hearing field was farther along when we started. There's now 3 meta-analyses that suggest without question that people who have vision impairments, various kinds of vision impairments, are at subsequent greater risk of having cognitive decline or new diagnoses of dementia. The question is why? So the red box down here shows that one real possibility is that there's just a common etiology that people who are at risk of their sensory organs having neurodamage are also at risk of their brain having damage. And so risk factors like smoking, vascular risk factors could put people at risk for both. And that might be why they co-occur more commonly than you would expect by chance. The other possibility, all these things in the yellow box, are that something about having vision or hearing loss in late life affects your brain's cognitive functioning in a direct way. So the study that I'm going to show you is one where we tried to probe, is it possible that when people develop a particular vision loss late in life, that it somehow has a effect on their brain structure or functional networks? So this is work that, again, I am not a cognitive neuroscientist. I'm a geriatrician, so it takes a village for me to be able to do a study like this. And some of the village, I don't know if Alex Badea is on, but she's been an important part of this, as have Guy Potter, Dave Madden, and then my colleagues in ophthalmology, Nora Ladd and Scott Cousins. And then this incredible team of students and postdocs who actually do, who are cognitive neuroscientists. What we did was we enrolled 81 age-related macular degeneration patients and 85 age-matched controls who had healthy eyes. And we collected data on them at baseline and then through 2-year follow-up. We did neurocognitive testing, health and lifestyle surveys, hearing testing, lots of vision testing, and then we did brain MRIs, functional MRI, as well as DTI at baseline and at follow-up. And as expected, the AMD group underperformed on the cognitive tests, both at baseline and in follow-up. And you can see particularly, and this is exactly what the literature would suggest, even in this small group of just 81 and 85 people, we could see statistically significant differences in their cognitive ability, particularly around sort of language and semantic tasks. So here's sort of the key discoveries so far from this data. So one is that the AMD group has worse white matter integrity in certain tracts. I'll show you here. This is showing tracts that differed significantly between the AMD group and the control group. And you can see the splenium pretty prominently lights up there. Not at all surprising when we think about, and maybe particularly thinking in the context of the case that we just saw of the stroke, so much information comes in through your eyes, goes through the optic nerves to the lateral geniculate nucleus, fans out in the splenium and needs to make it to the occipital lobe. And then all the processing that goes on to make us see things in the correct shape and size and color has to be transmitted back through the splenium for us to be able to make sense about that information, talk about it. So the splenium is sort of a superhighway when it comes to transferring visual information, making sense of it, and then also using that to produce speech and semantics to make sense of the world. So we were not that surprised in a way to see that perhaps when you take a group of older people that have and all these people had visually significant age-related macular degeneration. So they had vision impairment from their macular degeneration, and you've deprived them of that visual input for a period of time. The integrity of this sort of superhighway, we see differences in them and their peers. All right, another, using the longitudinal data and with Alex Padea's help, we were able to see that the AMD group also had a faster rate of deterioration, especially on the left side. So here's the data showing, again, group differences in change over the 2 years, the difference in those two MRIs. So not only did the AMD group at baseline have lower white matter integrity, but they had a faster rate of decline. In addition, from the functional connectivity pattern, we found this very interesting thing that we weren't exactly expecting to find, which was that there was a functional connectivity pattern that was associated with having AMD, but still having good cognition. So we looked at the relationship between your functional connectivity and your cognitive performance. And in the AMD group, what we found is that when people had better cognitive performance, despite the fact that they had AMD, so we're at risk of having bad cognitive performance in these verbal fluency tasks, if they had more activation in this bilateral frontal temporal network, particularly on the right side, those people who were engaging this bilateral frontal temporal network more on the right side at rest appeared to be those AMD patients who had preserved cognitive function. So these are the areas where we saw even corrected people in the AMD group, but not in the control group. This pattern of better resting state functional connectivity in this network, in this area, right-sided area, was associated with preserved function of verbal fluency tasks. So trying to make sense of all this, I mean, we think what we're seeing is it's clear that the group with AMD tend to underperform on cognitive tasks. That's consistent with epidemiological data. That group also has worse structural integrity and seems to be losing structural integrity at a faster rate than their peers. And then we see this higher connectivity on the right-sided regions of a bilateral frontal temporal network, which sort of looks like a language network, but on both sides. That was associated with what we're calling cognitive resilience in AMD. So it may be that efficient recruitment of sort of supplemental brain regions to your typical language regions may support cognitive performance. What's unclear from this is if it's people who were effectively able to compensate or recruit in the face of the deficit, or if these were people who always had a stronger bilateral frontal temporal network. And so they just sort of went into age-related macular degeneration with some protection. We don't know if they recruited these areas in response to the age-related macular degeneration, because this is observational data and they had AMD all along. Our theory is that underlying neuropathology, so if these people have high burden of amyloid or tau, it may make it more difficult to cope with vision loss. They may be less able to engage these other networks, which seem to be protective, and potentially vice versa. That's a piece that we can't answer with the study that I've done so far, because I don't know the biomarker status of these individuals. It's a study I'd like to do in the future. I think a ripe area is whether interventions that address sensory impairments in mid or late life have any impact on dementia risk. Could they potentially help a person who has dementia, who has underlying pathology associated with dementia, tolerate that better so that the symptoms appear later in life? There are 2 ongoing randomized controlled trials at other places that could provide some of those answers. One is the ACHIEVE trial, looking at hearing aid use. The other is a study looking at cataract removal in people who are already diagnosed with Alzheimer's disease. And these are just 2 interventions. Cataract surgery and hearing aids are just 2 ways to address and accommodate vision and hearing deficits. So there are lots of others. And I think this is a real area of opportunity as well. All right, finally, giving you the third example, probing the germ hypothesis in Alzheimer's disease. So what is the germ hypothesis? It's this idea that, interestingly, I think was first, I believe, proposed by Alzheimer himself in like 1906, that it was possible that some sort of exposure to a pathogen or a microbe late in life or earlier in one's life could trigger the development of the neuropathological changes associated with Alzheimer's disease. I would say that this hypothesis didn't get much attention until lately. There have been, I think, largely because of the very clear evidence that the inflammasome of the brain, the chronic inflammation and immune response in the brain through microglial cells plays a major role in the potential development and progression of Alzheimer's disease, which has now turned attention back to this potential idea that it may not be that a single germ is the smoking gun, if you will, but that exposure over the lifespan to microbes, either in our gut or mouth, or to pathogens, may cause a chronic inflammation that has effects across the blood-brain barrier and affects the brain. In addition, and the reason that this one is near and dear to my heart is it was the subject of our first symposium that we put on by the Duke UNC ADRC. This was funded by philanthropy. So Dr. Norens is a retired now alumni of Duke Medical School, very interested in the germ hypothesis and funded us to put on this symposium, and then also to have an award, competitive award opportunity along with it. So we had, for example, presentations by Rudolf Tanziyah at Harvard, whose work has suggested that amyloid may actually have an antimicrobial effect. So raising the sort of intriguing possibility that the amyloid may accumulate for a good purpose to try to control some sort of germ that is in the brain, but that then the amyloid begins to cause problems when it accumulates, creates becomes an inflammatory trigger in its own right, and ultimately leads to the development of tau. So lots was discussed here. The point of this conference was to try to identify sort of, to number one, review the evidence for and against this notion that infection or inflammation plays a role potentially in Alzheimer's disease. And then also to identify what are the key gaps, questions, where should the field move to start being able to either put this hypothesis to rest or identify opportunities that could lead to new strategies for treatment. So this is just an example of some of the sort of key areas that we ended up identifying, are these 5 that you see, focusing on microglia, the sort of macrophages of the brain that have both a phagocytic function as well as being immune cells. Thinking about the microbiome as well as autoimmunity and the general inflammasome of the body, and how that could potentially, as I said, have consequences across the blood-brain barrier. Thinking about brain metabolism and amyloid and tau and the interaction there with microbes that may trigger changes, specific pathogens, and then a focus on the blood-brain barrier to understand this germ hypothesis better. Then, as I said, there were 2 pilot awards were associated with this conference. And one of them is Dr. Quinones in ophthalmology, and his collaborators at Harvard are looking now at PNAG, or whether a microbial antigen, a sort of antigen that's associated with many different kinds of microbes, whether it's co-localization with amyloid in the cornea, might be able to distinguish AD patients from controls. This follows on an area that Sharon Feckrad and other colleagues at Duke have sort of led in thinking about the eye as a potential diagnostic tool to identify, to distinguish Alzheimer's disease, identify it earlier in the course, or to help distinguish it from other pathologies through changes in the eye, either retina, cornea. And then the second one was particularly probing a particular germ. This is one that Dr. Norens is especially interested in, P. gingivalis, which is a bacteria involved in gingivitis and periodontal disease, both of which in fact are highly age-related. So oral changes in the oral cavity with age, the idea here being that perhaps this allows what are normally not pathogenic, but mouth microbes to gain more access to the bloodstream and potentially contribute to pathologies in the brain. I'm just going to sort of show you too that the Lancet Commission, for those who haven't seen it, this is the 2020 report looking at opportunities for dementia prevention, intervention, and care. It also highlights a very lifespan approach to thinking about this disease. And I love this figure that they put together that sort of identify largely from epidemiological data where the opportunities might be along the entire lifespan. Their estimate was that we may be able to prevent or delay up to 40% of dementia cases if we modified these 12 risk factors. And if in fact it proves to be true that modification of these risk factors in early life reduces the risk. And I want to just stress again that this is a gap that needs to be filled. We know that these things are associated with dementia risk. It remains to be seen whether modifying many of these things will lower your dementia risk. But I think that's an important thing to understand. How are we going to understand that? So one thing that we have to do is start looking earlier. So obviously, if we continue to study Alzheimer's disease only by enrolling people who have Alzheimer's disease and their peers who don't as controls, we won't be able to test and look at these factors early on. So it requires longitudinal studies with a longer window to be able to see what the changes are in early and midlife that are associated with Alzheimer's disease, as well as how manipulating those can potentially reduce risk of Alzheimer's disease. So the people that we're recruiting locally and contributing to the national database are younger, also more diverse than has previously been enrolled. And this is due to the fact that, again, a lot of previous Alzheimer's disease research has recruited people from memory disorders clinics. And what we know is that if we exclusively use that as our recruitment strategy, the people who show up to subspecialty care at academic centers tend to be high socioeconomic status, highly educated. So they are a skewed sample of the actual population of people that are affected by this disease. So one thing that we are really trying to do is to bolster our enrollment here in Eastern North Carolina of Black, American Indian, and Spanish-speaking patients, and people from rural North Carolina. We collect biospecimens across early and midlife. And then we have a particular focus and interest in perimenopausal women. So we're trying to recruit a large sample of perimenopausal women. We're enriching this cohort. And I just want to give a nod here to a person who's shown on the screen there, Kim Johnson, who is the director of the Memory Disorders Clinic and the associate leader, along with Rich O'Brien and her counterpart, Heidi Roth at UNC. They are doing an incredible job of bringing in these participants who also make an incredible contribution of their time and energy in samples, cerebrospinal fluid and blood to this fight against Alzheimer's disease. So it is no small feat to be able to achieve what we're trying to do here in terms of to convince asymptomatic people in mid and late life to come in, spend this much time with us and contribute of themselves in this way. We also collect a lot of novel data and biomarkers that were not required by the NIA to collect. That includes retinal imaging, digital biomarkers, high resolution advanced MRI techniques, thanks to Alan Song, and then the sensory and mobility measures is a special feature. So in summary, what we are trying to be is sort of the friendly neighborhood concierge for Alzheimer's disease research. We host an increasing number of events. Symposia are coming out, so look for those announcements. And our hope here is that if a postdoc and our mentor walk out of a symposium, maybe they don't study Alzheimer's disease at all. Maybe they're immunologists that study an entirely different thing, or maybe they've studied a different disease, Parkinson's or ALS, and they have a new idea based on something that they've heard about how something they know might be relevant to Alzheimer's disease. What can we do to help them? Well, we can potentially help them find access to people that would be interested in being in the study, to stored blood, CSF, brain specimens. If not stored here locally, we can point to some of the national repositories, connection to experts and collaborators, didactic training or mentoring through our research education core, analysis of novel biomarkers, access to data sets and analytic expertise. I think I saw Mike Lutz, who runs an incredible operation within the ADRC that has already created something called the Arena, which is an integrated data set where you can go and search yourself for how many samples we have of different kind of people. You might say, I want to see how many people you have between ages 45 and 60 that have an ApoE4 allele. And there's a system that you can go and do those looks yourself. And then pilot funding. So I'm going to stop there, and I'd love to take any questions.
Yeah, thank you so much, Heather. Before we get to questions, I just wanted to show one other slide. This is a slide I put together last night on leadership and establishing an ADRC and running it. Can you see it? We got the frogs in a wheelbarrow and the herding cats themes going on. And you
sometimes I think we're herding lions, though, because the cats are all pretty powerful.
All right. Anyway, thank you so much for the talk and all you've done. So I think the first question was from Kathy Welsh-Bomer. Kathy, do you want to ask a question?
Yeah, great presentation, Heather. I was curious with your EMD data about, particularly when I saw the activation in the right frontotemporal area, about handedness and whether or not you controlled for handedness in your population. I came in late, so I didn't hear.
Yeah, thanks. I didn't mention it. They're all right-handed.
Okay.
Yeah.
Thank you. Mm-hmm. Yeah, I mean, the reason I asked is for the others, and people probably know this, that in stroke, you can sometimes see different kinds of compensation if you're a mixed-handed person or a left-hander. And so in neuropsychology, we pay attention to that, particularly with verbal fluency tests. Thanks.
Shout out to Kathy too about the work that she's done and actually has been doing and leading on the national level to accomplish, as I said, one of the heavy lifts that we're trying to pull off here is to create a cohort like no other, and that it's more diverse and representative of Eastern North Carolina, and that is no small feat. And Kathy's been doing this for decades. So,
thank you, Carmen. Are you still out there?
Yeah, and I think Mike Pitek kind of answered part of that. There was a really interesting multi-center clinical trial presented last week at the International Stroke Conference, where they randomized patients to aggressive oral care with fully paid 4 visits per year and deep cleanings versus a toothbrush and instructions to just brush every day. And there was a substantial reduction in stroke outcomes just by the aggressive oral care. Given how much inflammation seems to play a role in dementia as well as in microvascular cerebral disease, do you think with the background of that stroke study being so overwhelmingly positive, do you think it's the right time to look at a randomized trial of aggressive mouth care in patients with mild cognitive dementia to slow down the progression?
Yeah, thank you for that question. I actually wasn't aware of that data. That's fascinating. And then there's someone, Bei Wu, some of you may know was in the School of Nursing. And I'm actually not sure where she is now, but she has been one of the leaders in mouth and oral care.
Well, the PI for that study is Dr. Suvik Sen, who used to be at UNC and is now the
Okay.
chairman at Columbia University in South Carolina. So they're literally, 2.5 hours drive away. If you ever needed the logistics how to pull off this kind of a trial. It was mostly in African Americans underserved, so they really enriched it with a high risk population. But I think it would be a fairly neat study to do. And since mouth care is not generally covered, it could make a strong argument that this is a critical part that should be covered by insurance and Medicare.
I love that idea. I will follow up with you.
Wayne, do you have a comment on vascular disease and dementia? That's a big issue in the stroke world now.
Well, so of course, if you have a stroke, going to cause significant cognitive impairment. So that's almost established. I do want to make a comment actually on the gum disease. Actually, in the 1980s, there's a lot of data that suggests patients have a gum disease. They also have social carotid disease, and actually, when they isolate carotid plaque, they actually can isolate those bacteria, which is actually traced back to the gum disease. But then kind of research really kind of didn't really continue on these things, but it really early days. But I think probably mouse care getting better. But worldwide, 60% of population still struggle with gum disease. To me, this is quite a bit, low-hanging fruits and to work on this. As Carmen pointed out, the data was presented at IC and is very impressive. The p-value was not a significant part of their follow-up time is not adequate, but the difference still very substantial. I had a discussion with Suvik, and they are certainly plan to do a little bigger study, a little longer study. That may be great, and kind of tag on and look at a cognitive status as well. So,
okay, thank you, Alex. You had a point, Adea?
I just had a very silly question, and I apologize for that. But how do you measure success in lowering the risk and slowing down the progression?
Yeah, so I think that we don't know that we've lowered the risk until we have randomized data to prove it. And then the outcomes, the challenge of these studies are that they take so much time. So if we're going to try to alter something in midlife or even, early, late life, and then we have to wait to see if the outcomes happen. And on a 5-year funding cycle, that's the challenge. I've even asked this question to, Dr. Hodis, the NIA director, how do, this is a real challenge, because everyone sort of agrees that the missed opportunities right now for preventing dementia are in midlife. And it's a design challenge for the studies, but I think we don't know until, we have, and to your question of how do you determine if they have dementia, I think we have to do it the right way. I think we have to have consensus diagnosis, and also those are, it's not an inexpensive or low effort thing to do. I think too many studies have relied on, for example, trying to detect dementia in electronic health records, which we know is many cases are often missed, and it's not it's meaningful missingness in that people who are of lower socioeconomic status are less likely to be diagnosed with dementia, even though they have it.
I will wish you good luck in renewing this project a few times so that you actually have the chance to follow these people.
That's what I'm hoping, and hopefully this team will all stick around long enough and keep following them with me, because the payoff is going to be in 15 years or more.
Now, Heather, there are no other questions, so I'll take the last one. So a lot of the changes that might be beneficial involve behavioral modifications, which, you know, I couldn't be more cynical about. I mean, your husband is a rare exception, gives up the cigars, exercises more, eats better. In the field of geriatrics, is there any better data that behavioral change actually happens when people get older? Do they get wiser and more able to change what they do, or they become more hardened in their ways?
Yeah, there are people that might know the answer to that question better than I do, but I would say we have a Roybal Center here at Duke. So kind of a cool thing right now is that the NIA has 4 major P30 centers that it gives. We now hold 3 of them. So the Alzheimer's Disease Center, the Pepper Center, and the Roybal Center. The only one that Duke doesn't have is the Shock Centers, which study basic biology of aging. And so the Roybal Center studies exactly that. How do you modify behaviors in late life? So that's led by Janet Becker. And I think there'd absolutely be opportunities for us, and it would be received well for us to collaborate with them in that space.
But no, a lightning bolt doesn't hit you at 70 and then you start behaving better.
Especially, you know, there's a lot of thought around for people who have mild cognitive impairment. How do we do any rehab or any kind of behavioral modification in people that have mild cognitive impairment who could benefit from it greatly, but extra help to make those changes?
Yeah. I agree. All right.
I agree. My husband's pretty extraordinary.
No doubt. So anyway, Heather, thank you so much for all you do and for your wonderful talk today, and everyone else have a safe day.
Thanks for inviting me.